So thank you. As you can see, that there are a lot of questions that are ongoing right now in relation to the drugs and which one is better and where to place these drugs, first line, second line, or other. So what I'll try to do is sort of bring that to some sort of close where we can then discuss in 8 minutes. There we go. So we'll talk about melanoma and go forward. These are my disclosures. As you can see, immunotherapy has had a huge role. If I had did this talk 5 years ago or even 3 years ago, only 4 or 5 names would be here. We've made major advances in metastatic melanoma therapy, going from 1-year survivals around 25% to now 75 and over percent response rates above 50%. But where has that brought us? And where will it go? I will caution that this is not a melanoma talk. A majority of the data that you've seen prior to this in lung cancer and other solid tumors has come from the melanoma experience. What I present here today will be evaluated in many solid tumors and will move forward in all solid tumors. Therefore, I encourage you to think about this as a treatment talk for multiple solid tumors. At the Angeles Clinic, we have combination immunotherapeutic trials for every solid tumor and newer checkpoints for patients who have failed single agent or combination PD-1 trials. And that's the future, because we have a huge bridge to gap. While you get 30 to 40% first-line response rates in single agent with melanoma, that's not the case with other solid tumors. Whereas breast cancer and others where you can sort of subcategorize MSI high and get high response, head and neck HPV positive and get high response rates. In other solid tumors, we're not getting high response rates. We have to do better. And that begins by understanding what targeted therapy means in solid tumors. Targeted therapy is nothing new for melanoma, and the approval of BRAF and MEK targeted therapy as dual checkpoint and dual targeted inhibitors of the BRAF pathway, MAP kinase pathway, are now standard. Single agent therapy, in my opinion, is some sort of misinformation and malpractice. But BRAF and MEK targeted therapy makes a lot of sense in many solid tumors. 8% of solid tumors have the BRAF mutation. The approval in lung cancer indicates the role of this, and in colorectal cancer. This is the long-term data presented in melanoma from dabrafenib and trametinib, and I bring your attention to the approved doses here. What we are showing now is the overall survival, and what you can see here is 5-year survivals that are similar to what we've seen with immunotherapy. The importance here is that there has been indication that targeting the BRAF pathway is immunostimulatory. When we look at these patients in subgroup by LDH, you find that those patients who have a lower LDH, lower than the upper limit of normal, they do better, 45% 5-year survival. So I challenge you to find a regimen that gives you that, even single agent PD-1. And when you look at what has been shown before by Georgina Long and others, when you take those with low LDH and less than 3 sites of metastatic disease, you find long-term survivals here of 50%. So indicating who those patients are who benefit the most. It's not what we thought before. It's not the high volume, fast progressors, high LDH. It's the low volume, low LDH patients. This is the longest follow-up for BRAF inhibitor combination and shows a significant 5-year overall survival of 28% and subgroup benefit. And that's important as we think about every solid tumor moving forward. The longest data we have to present is KEYNOTE-1 and KEYNOTE-6. This is a trial, KEYNOTE-6, of pembrolizumab versus ipilimumab, and patients randomized to pembro at 10, every 2 or every 3 versus ipilimumab. It's clear that first-line PD-1 therapy with any PD-1 is better for survival than ipilimumab, and that's been shown. But now when you look at these survival curves, you understand that there is a new phenomena, which is a shift in survival, where you're looking at 2-year survivals with ipilimumab at 42 and 39%, and that's a trend because not just because of the ipilimumab, but a transition to other therapies in PD-1. and you're looking at 2 and 3 year survivals around 50%. This confirms first-line therapy with a PD-1 backbone is important, but this trial presented by Carlino Ribera answered a question that everyone else is talking about in every solid tumor. When can you stop? And these patients had a hard stop at 2 years based on partial response or complete response. And these are the patients who were responders and the patients who were stable, and what happened to them at this time point at 2 years where they came off of therapy. As you can see with these little tiny dots, the majority of patients had responses early, first time point at 12 weeks. And as they continued to be treated, some went from stable disease to partial response, and some went to complete response, as you can see here. Even patients, and I urge you to look at this, who went off of therapy as a partial responder and then continued to have immune response to a complete response. This shows that we may be over-treating patients, that we can stop at a time for these patients who are having response. What's most important here is these patients who came off, looking at their status many months from stopping therapy, average 10 months, you can see that those complete responders and those partial responders, which make up 92 patients, had a greater than 90% progression-free survival. So they continue to have benefit. And we have data showing that once you lose that benefit, you can re-induce with PD-1. Unfortunately, those stable disease patients was only 83%. So the question remains whether those patients should be continually dosed, should transition to another therapy, understand what the limit is to getting the immune system more stimulated and transitioned into a combination or other. The summary is a median overall survival of 32.3 months. That's important because when I was running around the county hospital with Dr. Arzu there, the median survival was 6 to 8 months. We've done a phenomenal job, and we'll do it for every solid tumor. But the next step was combination. And the combination of ipilimumab and nivolumab has been presented to you multiple times in many solid tumors. It begins in melanoma, and the Checkmate 67 trial was a randomized triple-blinded study of ipilimumab and nivolumab versus nivolumab alone versus ipilimumab. True that it was powered to look at the combination and single-agent nivolumab versus ipilimumab as far as survival and otherwise. It was not powered to evaluate nivolumab as single agent versus the combination. But here's the data presented by James Larkin, looking at just that at AACR. And surprisingly, we saw overall survivals at 1 and 2 years with the combination and single agent nivolumab, here 73, 74, and 69 to 64%. Phenomenal, as historical was around 15%. But what we do see here in an analysis between Nivo and Nivo-Ipi is a hazard ratio that's not significant. We have not improved survival looking at 2-year time points. Now you see that this remains different, and there are multiple events still waiting to be reported and will be updated at ESMO. But at this time, you cannot say there's a survival benefit. Subgroup analysis has been done, and there is an indication that maybe the BRAF mutants are those that present with less than 1% PD-L1 are the patients that benefit. But this is a subgroup of a non-planned analysis. And I bring to you forth the fact that PD-L1 is not going to be the right predictive marker, that we need to do more and understand more. Specifically, since you have toxicities such as this. Grade 3 or 4 toxicity in this combination regimen was near 60%, with 30% of these toxicities leading to discontinuation. These, the majority, are manageable, but there are things like myositis and cardiomyositis that causes death. Diabetes type 1, etc. So we're looking for better combinations of Ipi-Nivo, whereas this combination is no longer being used in other solid tumors and is going by the wayside, and we're looking at other combinations which emphasize the nivolumab greater and decrease the ipilimumab. What else are we doing? Dr. Santos described epacadostat, which is an indolamine deoxygenase inhibitor, which IDO catalyzes the change of tryptophan to kynurenine, and that's immune suppressive in the tumor microenvironment. So looking at targeting other places in the immune system and looking at predictive markers like IDO staining is important here. This is data that's been presented in combination with nivolumab and pembrolizumab. It has already accrued 600 patients in a randomized trial of pembro versus pembro epacadostat, which will be presented soon. And I'll update the pembrolizumab data in the phase 1/2 at ESMO this year. What's interesting here is the response rates that we've seen, albeit in 40 patients. In untreated melanoma, overall response rate of 63%, mimicking what we saw initially with IPI and Nivo. And a disease control rate near 90%, mimicking what we've seen with BRAF and MEK. What you can see here, and if I took this title off, you would think this is IPI-Nivo or any combination. In these waterfall plots, a significant benefit and complete responders here. But in the spaghetti or spider plots, what we want to see always, deep, rapid, and durable responses with these patients. Importantly, when we looked, responses are ongoing, and the toxicity is similar to single agent alone, with a slight uptick in rash. This is a combination that can prosper in the community, that has less toxicities, hospitalization, and phone calls to the physicians. Where else did we go? An exquisite study presented by Paula Esierto from Napoli was atezolizumab. I'm sorry, let me back up. Let's bring BRAF and PD-1 together. This is something Ryan Sullivan, ourselves, and Patrick Hu have presented multiple times. Combination of VEM-CoBi, BRAF MEK, and atezolizumab, 100% benefit, deep, durable, and a randomized trial is ongoing looking at this combination of the BRAF MEK versus the triplet. But we've been now speaking about immunotherapy and the next step. And the next step is looking at other immune targets. In fact, starting with other checkpoint inhibitors and other checkpoint activators, OX40, GITR, and CD137, also known as 4-1BB, not only stimulate the T cell, but have activities in downregulating the amount of Tregs, in stimulating memory T cells, and enhancing the immune microenvironment. Other inhibitory targets like TIM3 and LAG3 are available, which have shown to have minimal single agent response, but possibly a benefit in combination with less toxicity. Here's the aforementioned trial with Pablo Esierto presenting LAG3 antibody in combination with nivolumab in patients previously treated with any type of PD-1, PD-L1. As an aside, my belief is that there is no clear difference that we can find between all of these agents that are approved. In melanoma, there are 2. In bladder cancer, there'll be 50 by tomorrow. LAG3 is an immune checkpoint that leads to stimulation of the T cell in the microenvironment. This data, thank God you get these slides on your disk, but these data showed a response rate in failures that was significant. But when you look at those patients, this is greater than 1%. When you look at those patients that had LAG3 staining greater than 1%, compared to less than 1%, you're looking here at a clinical benefit that looks significant, you can tell, and a 20% response rate. This is an indicator that we have a way of understanding who would respond. Patients that progress, look at their tissue, what's their LAG3 staining, bring in this combination, and enrich for response. This is how I see immune therapy trials moving in the future. Since we have 300 combinations available, my opinion, and the opinion at Angeles, is small studies looking at combinations and looking for patients who are not just responders, but those exquisite responders We have biopsies pre, post, during, skin, blood, circulating tumor cells, etc. And then find out why those patients are exquisite responders. Why do I have a patient with ovarian cancer who failed therapy but responded well with a combination of an anti-GITR antibody along with nivolumab? Find that out, and then you can arrange for the best predictive markers and the best trials for patients. And this is the LAG-3 story. So the potential implications here already happened. A large study looking to see this response rate in melanoma, and then hopefully for lung. But as I've said before, we've been moving blind. We're designing trials to look for the benefits. We now know that we have benefits, and we need to design more intelligent studies moving forward. And those can be done by looking through predictive tools such as liquid biopsies. Now at ASCO this year, there was a preponderance of data showing circulating tumor DNA being a great indicator for response, not just in melanoma. Great poster with durvalumab and transitional cell carcinoma of the bladder, showing those patients whose circulating tumor DNA levels come down are the ones that are responding and have durable benefit, and that you can tell when they stop having benefit. And that's basically what this shows. With liquid biopsies to evaluate the patient, and then when circulating tumor DNA, so this is before initial therapy, then if it continues to go up, surgery or other definitive therapy, and then monitor to detect a recurrence, initiate therapy, monitor for response, and then monitor for evolution, not just recurrence, but clonal evolution, and then tailor therapy for that. Now, where has that been done? I'll tell you at ASCO. This is from Jenny Lee and the group at the Melanoma Institute of Australia. You'll be familiar with Matt Carlino's name and Georgina Long's name, as they've been leaders in understanding circulating tumor DNA and immune therapies in melanoma. In short, this looks at patients who had a mutation to follow in circulating tumor DNA and looks at their profile during therapy and whether they went from a high copy number or no undetectable number, kept it undetectable, or went from high numbers to low numbers, or high numbers to undetectable. These were favorable. Those who had no change were unfavorable, and they looked to see what that meant. These circulating tumor DNA profiles told you that those patients who responded had favorable profiles. Those who didn't respond but had favorable profiles still ended up doing better. This is overall survival. And most interesting, and I didn't put it much in there, is that if you had a patient being treated with immunotherapy, where at the first or subsequent imaging, you saw some minor growth, you didn't know whether this was pseudo-progression, whether the immune system was still in its way of checking in, or whether this was true progression. Circulating tumor DNA levels could adequately tell you who those patients were. So if you had a question and those levels were favorable, the indication was to continue therapy. This is early, not ready for prime time, but is the next step in immunotherapy. This discussion about PD-L1 staining or what's the best PD-1 is history. And the PD-1 that will benefit in the future and will come out on top will be the one which will have the combination and the indication that has the higher response rate and benefits. But immunosuppression is multi-layered, and this was put forth by James Gulley at one of the ASCO reviews, that we need to understand tumors just like we understand an onion, that there are multiple layers of immunosuppressive stroma, whether it's just the checkpoint, nutrient-depleting enzymes. We talked about IDO. There's data with arginase inhibitors and response after PD-1 resistance. Problems with presentation and bispecific antibodies overcome that. Apoptosis genes, etc. And this is more of how we should be starting to think about our treatments and how we're thinking about it in melanoma and other solid tumors. evaluating the tumor microenvironment, inflamed or non-inflamed, and then subcategorizing what we see as predictive markers. In short, if you look at one that doesn't have, for example, there are no T cells to bring in, combinations with anti-CTLA-4 that has been presented by others in prostate cancer. Prostate cancer, there isn't a lot of T cell infiltrate, but when you combine with ipilimumab, you see the influx of CD8 T cells, or other checkpoints that we've talked about. If there's no MHC, bispecific antibodies are available now and are being presented. Bispecifics have shown response rates in ocular melanoma, an immune intolerant tumor that doesn't respond to chemo or others, is showing long-term durable response with bispecifics. We've also talked about bringing T cells in and the immune suppressive work of VEGF and the renal data that was presented prior to my talk. But if you look at the environment, the tumor microenvironment, and IDO is overexpressed, an IDO inhibitor and otherwise. And this is from Chen and Melman, who are at Genentech. In the time I have, I'd like to just touch on 3 different things. Early therapy, adjuvant therapy in melanoma, and we've seen with ipilimumab versus placebo an 11% increase in 5-year survivals that led to this approval of ipilimumab. The next step was to take the next drug that worked in melanoma, and trials comparing ipilimumab to anti-PD-1 therapies, and lower doses of ipilimumab have been evaluated, and this is what's out there. Pembrolizumab versus interferon, pembrolizumab versus observation. This will probably be presented at ESMO. Nivolumab versus ipilimumab. These have all accrued, hold that thought, and will be presented at ESMO. We're also looking at a trial that's ongoing now at our institute, nivolumab alone versus ipi alone versus the combination. That's just started and is accruing. And then BRAF targeted therapy. All of these accrued studies, I expect to have some sort of presentation in the next couple months at ESMO. But as I was putting this talk together, this came out, and we already now know that there's improved relapse-free survival versus ipilimumab with PD-1 therapy. So hold on, because that's going to be the next step in adjuvant. And this is, as you've seen in the lung cancer talks, where adjuvant lung cancer therapy, adjuvant bladder, and adjuvant others is going. Brain metastases is always the thing at the top of my mind, no pun intended, when I talk to patients. Patients with melanoma have metastatic melanoma have a greater than 50% chance of having brain metastases historically. And this is a trial we were fortunate to be part of, presented by Hussein Taubi at MD Anderson, of the combination of ipilimumab and nivolumab. This is the place to go with combinations early, and those late failures. Here's a patient with brain metastases that we would usually radiate or surgically resect, discuss evaluation, and watch progress. But here's the response rates in these patients with, as you can see here, overall response rates intracranially and extracranially equal, 55 and 49%, and a benefit rate of 60%. What does that mean? That means this person, without radiation or whole brain or surgery, turns into this person. And I currently have a 2.5-year survivor like this. So this data will be updated and represented. That's Checkmate 204. Targeted therapy has shown the same intracranial responses that are 50 to 60%. Unfortunately, these responses are not durable with an overall response duration of 6.5 months. This is in combination targeted therapy where extracranially our control is somewhere around 13 months. So the next step is, what about combinations? And those are upcoming. Rechallenge with BRAF was presented, and in short, if you run out of options, Rechallenge has shown responses in patients that discontinued for progressive disease or for response. And as I end, real quickly, I'll say we need to have better clarity of whether our therapies are working. This is a trial opening with a mini-body. This is a PET target that targets CD8 T cells in tumors. It's been looked at in animals and will be looked at humans, getting PD-1 and other immunotherapy. And if we can show that early on that these T cells are trafficking to where we know there's tumor, we can have an indication of response. But if I did a scan and I saw nothing trafficking, then there's an indication to change therapy early rather than waiting for 12 or 16 weeks. The microbiome is coming at you, and we now know, presented by Jen Wargo, that patients with, this is a trial looking at the oral and the fecal microbiome, look at PFS and response. Those that had a greater fecal microbiome had a better response rate, and the oral microbiome did not matter. And now we're using these pre and post on every one of our patients. I do also see other solid tumors, and in short, Regeneron presented their anti-PD-1 antibody in unresectable and metastatic squamous cell carcinoma. You can see here there were complete responses and an overall response rate of 46.2% in patients like this. So we're not talking about a small squame here. Expected to see in basal cell carcinoma, same drug being looked at along with pembrolizumab and others in patients who have failed hedgehog inhibitors. And in Merkel cell carcinoma, we were fortunate to be part of the trial that led to avelumab's approval with a significant response rate. Merkel cell carcinoma is a high mutational load tumor. In those that are Merkel polynomial virus negative, they have a UV signature with high mutational load, and in those that are viral positive, they have high neoantigens. And we were looking at that in first line, and this data was presented with a response rate in the first line of 62.5%, which is going to become standard. So as I close, I thank you. I've made up about 4 minutes, and I give you my numbers and email if you have any further questions or would like to discuss a patient.